All right, thank you again, everyone, for joining today's webinar, Dissemination and Implementation Science, What It Is and What It Is Not, with Dr. Ross Brownson from Washington University in St. Louis. Today, we wanted to take you through this webinar interface that you see on the slide in front of you. So to the left of the slide is where the PowerPoint slides will be presented. And to the right, you'll see this attendee view of the panel, side panel box that will allow you to engage with us throughout today's event. So I'll go to the next slide and give you some brief instructions on how to navigate this attendee panel. So over here, you see the orange arrow. That will allow you to open and close your panel as such. From there, we look at the audio pane, which will show you which way you choose to engage. We generally recommend that folks dial in using the telephone. And once you click Use Telephone, that will show you the number, the access code, and what's very critical here is the unique audio PIN. If you are already on the call and you have not been able to connect the audio, please dial the unique audio PIN that is displayed in your participant panel. Another way that we would love for you to engage today is by raising your hand. If you have any questions towards the end of the presentation, we're going to open it up for Q&A. We'll reserve at least half an hour for that. And if you would like to share your question verbally, we will unmute your line. As you may have seen, everyone is currently in mute mode during the presentation. You may also choose to submit questions through the text box, and you can submit those for a question for staff or for the presenter. And again, the Q&A will be happening during the second half of today's presentation. And this session is being recorded, and everyone will receive an email within 24 hours with a link to a survey about today's webinar. And we will be posting this on our NCAI YouTube site for further record. So hopefully all of this makes sense. Again, if you have any questions, please feel free to raise your hand, and one of us as organizers will support you in making sure that you're able to participate to the fullest extent. So at this point, I'm going to turn the presentation over to Dr. Ross Brownson, who we are honored to have as our presenter, and he will be taking us through his presentation on dissemination and implementation research. Thank you again, Dr. Ross.
Thanks, Sarah. And Sarah, as we go through, if they want to type a question in along the way while the presentation's going on, that will work as well, right?
Absolutely.
Okay, good. Well, then that's another thing for people to think about. If you've got a question that if we were together, you would raise your hand and I would ask it, go ahead and just type that in and we'll be ready to roll. Thanks, Sarah, for having me on today. I'm glad to join the group and give it this introductory talk. I know there are several on the line who are experts in D&I research, and so this will be a very basic overview for you. And those of you new, hopefully they'll be a little bit new here. And they're also in sort of the 2/3 of the way through, I'll talk about some capacity building, training related sorts of things in D&I research. And so briefly, this will be my talk part of this will be 30 to 35 minutes. And I want to cover some basics around D&I research, in particular how it's relevant and important for those of you, most of you, I think, if not all, working in the area of health disparities, some of the differences between D&I research and other types of research. We'll do that with a little quiz that we've created, and then some resources for helping to do more in this area. You'll think back to your 7th or 8th grade civics class. You'll remember we learned about the different explorers, or I guess this is more earlier, maybe history class before this. Learning about the discovery of the New World, and here we have Vasco da Gama, the Portuguese explorer, way back around the year 1500, where at that time vitamin C deficiency, scurvy, was a very serious cause of death. And you see more than half the people would die of scurvy on a travel. And then you go around 1600, where began administering lemon juice, and we saw a much drastic change in the rate of dying from scurvy. And then we go further in James Lind, and he did one of the first randomized trials, and in around 1750, and we see further benefits all the way up to around 1800, where we had the first order, and then we had finally in 1865 the British adopting a policy. And you see a mere 264 years from the first knowledge about this till adoption in a policy. So kind of a long time frame. If we move more recently, this is the famous quote that we see that it takes almost a couple of decades for original research to benefit patient care. That comes from, we don't need to worry about much on the left-hand side, but if you think about conducting a study, submitting it, getting it reviewed, getting it accepted, then getting it published, making its way into a database, and then eventually making its way into some kind of a professional guideline or textbook, and then implementation, best guess is that it takes about 17 years for 14% of original research to benefit patient care. So this is kind of the famous quote that people use when they're talking about D&I science that says we have a long gap and we need to do something about it. May not be the 264 years that we observed with scurvy, but still, I think, unacceptable in our modern society. Another way, and this is kind of a takeoff on Russ Glasgow's work around the REIN Framework. Let's say we have a physical activity intervention that we would use in diabetes prevention and control that's 100% effective. Well, it depends on if it's adopted. It depends on if people are trained to deliver it properly, if it requires training for practitioners. It depends on whether the practitioners, even if they're trained, deliver it. And then it finally depends, maybe there's some side effects of this, or maybe there's opportunity costs, and you have to decide if populations will receive it. And if you look at kind of a 50% drop-off along the way there, you have this drop-off at every level. Some people call this the voltage drop. And at the end, even for something that in theory is 100% effective, you only have a 6% population benefit. And that's kind of what D&I is doing. It's kind of taking apart those pieces in the middle to see what that drop-off, where it's occurring, and how we can do better. It's just about baseball season. Many of us around here are baseball fans, so you'll know the famous baseball movie called Field of Dreams, and the quote, you know, if you build it, they will come. I think too often for our interventions in diabetes and elsewhere, we've sort of assumed that if we build it, if we develop a new intervention, if we, you know, publish it in our top peer-reviewed journal, that suddenly practice and the broader population will magically take it up. And we know from many fields of research now that that doesn't just happen. Some people have called this the NoDo Gap. We're not doing what we know we should be doing. Famous article that Beth McGlynn published about a dozen, I guess now about 14 years ago, was roughly half, I think this stat is actually 56% of the time when you have evidence-based care for prevention and control, with a well-documented study that we're only doing about half of what we should be doing, which people often call evidence-based medicine. And so that's the gap. And some people have called this a chasm as well in the IOM literature, in the Institute of Medicine. There are many different areas we could look at. Similar things that a large percentage of the patient population doesn't get proven treatments. And others, there's overuse, there's even use of things that are potentially harmful as well. And so it isn't that we don't know what to do, it's that we're not doing the right things and we're not doing things the way we should be doing. Some people have also called this the push-pull dilemma, that we tend to push things out regardless of what the pull of practice and policy is. This little cartoon, you know, someone doing snow cones, to someone up in Alaska. Trust me, Heracle, it's not or demand, it's supply and demand, that we have the supply but we don't have the demand. And we have that for many of our evidence-based practices. This op-ed was really nice by Stephen Wolf. And that last one I think is especially key in our current times. Every dollar Congress allocates to develop a new breakthrough, it allocates about a penny to ensure that Americans actually receive it. This is kind of the D&I part of the equation. I've seen those estimates anywhere from a penny to maybe 3 or 4 cents, but whatever it is, it's a small percentage of what we do on discovering new research versus applying new research. And especially important, I think, for inequalities, or in the U.S. terminology, we often use health disparities as the terminology, that we're trying to level the playing field, in a sense giving everybody an equal opportunity to be healthy. That's kind of the basis for reducing or eliminating inequalities. That can be determined by race and ethnicity. As you well know, these stats, whether it's African Americans and infant mortality, the topic of our work on diabetes-related mortality for Hispanics or American Indians, where it's 2 or even 3-fold more likely to contract and die of a disease. And then for cancer, varies very much by cancer site. Just as an example, where Vietnamese women are 5 times higher to have cervical cancer. And then it can be divided up by socioeconomic status or by health literacy, both knowing about the technology of health as well as resources for health. It might be based on immigration status. It might be based on the presence of comorbidities. It might be based on an urban-rural differentiation or some other characteristics, either of a patient population or a larger public health group, or of where people live or how they're treated or not treated. We know a lot more about the causes of disparities than we do about elimination. Elimination comes down to quality, access, and cost. It can include the reach of prevention programs, the scale up. That's a big D&I issue. If we know something's work, how do we get it to a larger population? It can relate to adaptation. How do we make, let's say, a program or policy developed in an urban setting relevant for a dispersed rural population? It can try to make policies more equitable. We're seeing that now in the debate over healthcare spending and coverage in the U.S. at the national level. And then it can relate to perceptions, how people think about health, how people take their own background and their culture and shape that to make either something health promoting or not health promoting. You've all taken on this challenge. We know that sometimes populations achieving health disparities are harder to reach. That comes into play in D&I work, just like any other area of health. And there's a gap between what we need to know and the application of this. And for disparities, often this gap is even bigger. So this is the part, if we were together, we would do this quiz together either by raising your hands or by doing a little poll on your phone. But we're going to do this on the phone this time. And so we're going to ask you some questions about the first one. If you look at these 6 different activities, if you will, news, beauty, pornography, contact lenses, evidence, and D&I science. Think about this. What do these all have in common? Well, maybe this is the famous saying that beauty is in the eye of the beholder. This probably applies to any of these others as well. To some degree, any of these is in the eye of the beholder, and we could kind of go through each one if we wanted to spend time on that. And D&I science, I'm going to give you some examples of why this is somewhat in the eye of the beholder, although I think the definitions and the terminology is becoming more clear all the time. I'm going to take a look at 4 different kinds of clinical or population level interventions. The first one is one for cancer. It's chemotherapy, a study that's looking at, and I'd like you to each think about, as we go through each of these, is this a D&I study or not, okay? And there's going to be 4 of them, so you can even mark this down if you want to. So chemotherapy. The objective is to determine the most effective chemotherapy regimen as measured by survival for people with stage 3 colon cancer who have not had treatment already, okay? So is that a D&I study or not? Question 1. Question 2 is a tool for health systems guidance. And this study is looking to develop a measurement tool designed to evaluate the methodologic quality of a health systems guidance a set of documents or a document, okay? So is that set of documents documents and the tools around measuring the quality, is that a D&I study, yes or no? Third one is a little more complicated, but it's a community-based randomized trial, so a cluster randomized trial. That's what the CRCT is. So this is to look at whether small media combined with audit and feedback is different or superior to small media alone, looking at the uptake of flu vaccination rates in an elderly population. Okay, so it's testing out these two different arms of a randomized trial in this population. Okay. Third one, and the fourth one is using clinical databases, the usage rates in the emergency room. So the proportion of patients who visit the ER within 2 weeks of death to compare patterns of practice in local integrated networks in different health regions, okay? This is sort of descriptive. All right. So these questions were developed from a colleague in Canada. I've tweaked them just a little bit for the U.S. context. But what we did, we administered these in a gathering of, and the Canadians call it knowledge translation, but it was a gathering of D&I, primarily researchers, but also some practitioners. And here's what we learned about for our 4 questions. So going left to right, the 4 questions, if you see the green bar, the first bar that comes on the left, they would say no, it's not D&I research. The blue would say yes, and the orange is not sure. Okay, so let's see what happens. Chemotherapy, looks like clearly people think this is not a D&I study. The second one, this one's a lot more mixed. So roughly equal, those who say it is and is not a D&I study. The third one, people clearly feel this one is a D&I study, almost unanimous, down just a few percentage who thought it was not. And then, oh, sorry, so a lot in the middle on the next one. And then the third one, I'm sorry, the blue, yeah, so the middle, a lot of yes. And then the third one, we have many on the left-hand side that say no, and then fewer, you know, a little bit in the yes part, and then some in the not sure. And so what do you learn from this? Well, even in a group of so-called experts, that there's not unanimous agreement, pretty good agreement about this one, the third one being a D&I study. But not much agreement on the second one. So let's look back at the one where people disagreed the most. That's this one. Well, why do we think they disagreed the most? Well, probably a lot of, and I'm going to give you the definitions in a minute, but a lot of the difference with what is a D&I study or not depends on whether there's an evidence-based basis for it, maybe an evidence-based intervention, evidence-based practice. So if these guidance documents are evidence-based guidance documents for this area, because we don't really give much about the area of health where this is coming to play, that's probably the difference there. This is kind of in the eye of the beholder. Well, it depends. And this is kind of a methodologic study. So is a methodologic study also a D&I study? This isn't really delivering an intervention. And I think that's why this one was clear. This one is clearly seen as a D&I study because we're doing vaccination, and vaccination is an evidence-based practice, and so that's coming into play here. And so the bottom line for our little survey is that even in these so-called experienced old-timers, I don't use that in the chronological way, but in the experienced investigators, it's in the eye of the beholder. There's a range of ideas. There's a range of whether it's evidence-based or not, and there's some challenges that would come into play when you submit a grant in this field. Do your review committees understand these basic definitions? And the definitions are here. And the 2 main definitions, and keep in mind, this is in the U.S. context, so this is how we would primarily define these if we were submitting a grant to one of our U.S. funders. You see with dissemination research, distribution of information, intervention materials to some audience. You're looking at the concept of spread and sustainability or sustainment, and you have this magic word of evidence-based intervention. Does something have an evidence base behind it, like a flu vaccination, that we should be doing? Implementation research is very similar. The big difference is that it's more specific about the strategies that would lead to adoption, and it leads towards some specific setting. So if you're doing a study in a school, let's say you were doing a nutrition study in a school setting, that's most likely going to be an implementation study. If you're doing a broad, let's say a media-related study that's covering many different sectors and using many different ways of spreading knowledge about an evidence-based practice, that's more likely to be a dissemination study. But there's a lot of overlap. I created this arbitrary table that tries to get at some of these definitions. Maybe implementation is a little bit more structured. These dissemination studies occur at kind of a broader, multi-sector level. These tend to be more at the organizational level for implementation. The target audience is a little bit different, a little bit on the larger community versus specific settings. The goals, the words like spread and sustain versus adopt and integrate. And then the levels are probably all levels from primary to secondary to tertiary prevention. I will tell you, if I was starting over in the U.S. world, I would probably not have two different terms. I would probably use a term similar to what the Canadians do and the Australians do, like knowledge translation. But we've kind of developed these terms with some reasons, but they are kind of messy, and it's important if you write a grant that you kind of start thinking about the kind of study you're doing and the terminology you need. Well, a little bit more about what we know, and some of this I've sort of already spoken about. We know that dissemination isn't a magic process. It just doesn't happen. You don't just publish a journal article and suddenly people start doing that evidence-based practice. Even if it's the best done randomized trial with clear results, a clear clinical benefit, it still just doesn't happen naturally and spontaneously. We know that we need active strategies. We know that just putting something out there without follow-up is not likely to be effective. The third one is kind of the idea of ecologic frameworks, that we know single source prevention messages, is putting out a media campaign without a policy change, or a policy change without provider input doesn't work as well. We know, and you all work in this area, but we know that stakeholders need to be involved, a variety of different audiences. We know that theory and frameworks make a difference, and they're beneficial both in understanding D&I and also conducting D&I research. And then the last one is important, especially for disparities. We know that the process needs to be tailored to different audiences. All these things inform D&I research in different ways. You'll know some of the terminology that NIH uses. I won't spend much time on this. You can see the citation here. This is an article a colleague here, Rebecca Lobb, did a few years ago. Early stage D&I research will be this T1, T2 kind of research, looking at efficacy trials, ideal world, beginning to look at effectiveness studies in T2. Then we get to T3, where we're starting to look more broadly into the real world, extending it, starting to putting into looking at things like external validity and systematic reviews. And then T4 is probably where many of you are working, and that's real world uptake of evidence-based policies and programs. And in many ways, D&I research is kind of unraveling that black box. If you've got this evidence-based intervention over on the left-hand side, and you've got a population change on the right-hand side, how do you unravel that? How do you figure out what the miracle is? How do you take apart this steps here in the middle part? A framework that a colleague, Enola Proctor, did here is kind of looking at the usual way we've looked at research versus all these things in the middle, especially look at the implementation outcomes, the service outcomes, which are focused in implementation. So it's the same idea as the black box. We're thinking about these things more in the middle, and it's a nice way of thinking about how research happens. Another article as background is this article from Glasgow and Chambers that looked at all these different characteristics. They looked at 14 different characteristics, and I just highlighted a few. The multi-level complexity is characteristic of a D&I study. The focus on scalability and sustainability. The idea of something being adaptive, that it's going to change over time, that we're going to adapt it to new time, new settings, new knowledge that comes in, And then this last one's really important, respect for diverse approaches and humility, which applies to many kinds of research. So let me spend just the last few minutes on talking about, okay, put yourself in the position of I'm interested in this D&I stuff in some way or another, and I want to put together the next phase of my work. And many times this happens to people when they're in the middle of a career. I worked for many years in etiologic research in epidemiology, and I realized that we can do all these studies in figuring out the causes of disease, but it's not really doing anything about actually improving health, because we almost know too much of the discovery knowledge and not enough about the application knowledge. And so if you want to make it happen, how can you make that happen? And in particular, how could you make it happen with some of the resources that Sarah is a part of and that several other people on the phone today are part of in this thing we call the Washington University CDTR, the Center for Diabetes Translation Research. Deborah Joshu here at WashU is the principal investigator of the center. You can see the goal, laudable goal, to reduce the disparities, to work in diverse communities. We're going to work both at the root causes and then prevention at a broad level, especially, I think, the T4 level, if you think of that, the NIH relationship. And we're organized here with us sort of bringing things together here in St. Louis, but then we've got the partnership with the NCAI, with Sarah and her team, and many of you across the United States. We've got another partnership with Shariki Kumaniki and Drexel, who heads up the African American Collaborative Obesity Research Network that has a large focus on diabetes prevention. And then we have the University of Missouri and Columbia that works a lot in the area of health informatics and using modern information technology to reach various populations, especially those experiencing disparities. We've got a network across the U.S. Here's our home state, but you can see where we've got other investigators who are part of our team. We've got this set up in a set of cores. So the first 6 items here are the cores that are available. So if you're a member of the CDTR, you have access to all these different cores. And then we have some cross-cutting programs, enrichment, which is sort of career development, building careers, and then funding pilot studies and feasibility studies. And some of you I know have participated in these, either from the core part of it or from the funding. And we could spend more time. The CDTR has a nice website that will illustrate many of these things. And of course, if you have a research center, you have to have a logic model or an organizing framework. And this is the organizing framework for CDTR and how we're focusing. And you can see it can focus on populations experiencing disparities. You can look at basically kind of the root cause of disparities. You can look at many things over here in the environment that can affect this. You can think of things early in life and later in life. And then our cores are meant to bridge all these things, to link them together. And a few other things before we move on to the question and answer part. Or beyond the CDTR, what are some other things going on either right now, I mean literally right now and in the next month or so, and then maybe in the longer term as well? One is NIH hosts a D&I conference every year in Washington, D.C., and I know some of you have attended that conference. It's very good. It'll happen again, I think, the same week roughly in Washington, D.C. This is the flyer from the last one in last December of 2016. So that's one to take notice of. There's a training that NIH sponsors that you can apply for. I believe there's no charge for the training itself, but you have to pay your travel to go there. This is done in 2 parts. There's web-based training that's done roughly from September through December, and then an in-person training is done at the same time with this meeting. Basically on the front end of this meeting, you get together for a couple of days to host an in-person meeting. So there's kind of a web-based part, in-person part. We have 2 trainings we host here, MT Dirk, which is one focused on cancer, and then the IRI is one focused on mental health. And both of these are funded through an R25 mechanism. That's just a grant mechanism through the NIH, one through the National Cancer Institute, and then the other through the National Institute on Mental Health. If you're thinking in the near future, we have an activity coming up that I think could be very helpful. And this is not only for D&I research, this is any related diabetes research. On April 21st, so roughly 5 weeks or so from now, we will host a one-day meeting with experts both from WashU and all over the country. We'll be here and we'll provide hands-on consultation to you on your diabetes and obesity research proposal. And we are hosting not only local people, but we have some travel scholarships. So if you're interested in that, I would contact Jen Gallagher as soon as possible. She can send you information about it, the details, and then what you need to do to submit an application and to get a travel scholarship to help you if you're not in the St. Louis region, and I know most of you are not. There are funding announcements. There are dedicated funding on different mechanisms from NIH. These cross institutes, so these are not only related to diabetes, obesity, these could be in cancer, these could be in heart disease. And so here's one listing of program announcements. There is a standing study section that focuses on D&I research and health. And then there's a series of related funding opportunities, and this is just a small set of 5 different program announcements that we put together that specifically focus on diabetes, obesity in a variety of settings, some very heavily focused on Native American populations, and some very heavily focused on D&I, a variety of different mechanisms. So, you know, there are opportunities out there. Obviously, the funding environment is tight, but I always say the one way you know you'll not get your grant funded is to not submit it. So the best thing you can do is work on this and try to get your work supported so that you can increase the reach of it. There are books out there. Our book on the left on D&I science, one from John Overveit from the Karolinska Institute in Sweden, and then one is sort of the Canadian version by Sharon Strauss and College on what they call knowledge translation. And I'll close with a cartoon and thank you. This kind of sums up, maybe I could have just shown this cartoon and not done the whole talk. Latest research shows that we really should do something with all this research. You know, this is the great epiphany that we had, you know, when this whole science of D&I work started, you know, roughly, I guess, formally a decade or maybe 15 years ago or so in the United States formally, that really we shouldn't be doing research for the sake of discovery. We should be doing it to try to improve the human condition, reduce disparities, make life better for the people that you all work with, and that's really what D&I research is trying to do. Many people who helped on the slides, so I want to thank this list of people and many more I'm sure that I've forgotten. And that's the formal part, so we wanted to leave plenty of time for question and answer. And so Sarah, I'm going to hand it back to you and let you take the screen back, and we can go through and see if we have questions.
All right, thank you so much, Dr. Ross. Really appreciate you lining all of that information out for us. I know there are a ton of resources, so again, I'll just let people know that we will be emailing out copies of the slides, not just the recording with all the information that Dr. Ross just shared with us, but slides so that you can access some of those hyperlinks that were shared out at the end. So at this juncture, if there are any questions, happy to take those. You're welcome to insert them into the text box again below. Type in a quick question, or if you have, if you'd like to raise your hand, I'm happy to unmute your line at this time. So feel free to start engaging with us. I guess just to start off, until we have some questions lined up here, I would ask Dr. Ross, could you share a little bit more about, you know, what I want folks to really have a clear understanding of the role and function and support that the CDTR in particular offers. This next event that's coming up, Could you share a little bit more about what that looks like, kind of hands-on, on-site? And this was done roughly 2 years ago as well, but the orientation then was more on publication. Is that correct?
Yeah. So this is one, we've done some versions of this previously here at Washington University on a variety of topics. And so the way it works is that people submit, I believe it's a 1 to 2 page concept paper. So basically you could take an Ames page from a research project that you want to work on that maybe you've submitted and want to resubmit, or maybe an idea you've had that you would like to submit for funding to some funding agency. The way we'll organize it is mostly around kind of the NIH world, but I think any funder is fair game, and you submit that, and then basically the day is a hands-on critiquing of that. So you have a series of meetings with different colleagues who can say, okay, here's your aims page, here's how I think you might reframe those aims to make it better. Or let's say you're submitting a small grant, they might say, well, this seems too ambitious, what's the most important part of this? Are there certain methodologic questions you have in mind? Have you selected the best study design? How could you couch this? All the way from sort of the technical aspects of putting together a proposal to, if I wanted to submit this, which part of NIH, how do I submit this to the right study section? Or how do I find some part of NIH or another foundation who might be interested in funding this? And so it's a very much of a hands-on working group. I think most of the day is not didactic presentations, but it's more working on small teams to basically to help you, each one of the people who are part of it as scholars, to help them improve their grant applications and their research proposals as they move it forward. And then the next step is really to get something ready to be submitted, and then following through on that with ongoing support from the various cores that are available that I listed on the slides that you'll have later on. That help?
That is very helpful. Thank you so much. And I know that from the last time around when there were publications that were papers in progress, that several of those did end up being published in kind of a standalone journal of sorts, which was really neat to see. So that's really what our hope is to support more scholarship on this area, and really to then drive that research to precisely to implementation in community context. We do have a question here. Dr. Ross, would you comment on the difference between D&I research and quality improvement?
Yes, good question. There are many parts of it that overlap. I would say the parts that overlap the most are that they both often focus on improving function in an organization. And so quality improvement might be looking at let's say a process in a clinical setting where your outcome might be the change in a process, or the increased productivity, or higher employee satisfaction, or something like that. The difference with D&I is often that the focus is on some evidence-based intervention. But there are many things in the organization, and people in D&I world often call this organization climate and culture, that really do link very closely with quality improvement research. And so I would say that if you're interested in quality improvement, a study or a project you have in mind can relatively easily be turned into a D&I study with a little bit of tweaking and the use of some of the terminology that applies. And I think that a lot of the quality improvement research has come out of organizational psychology, the business literature, some of the areas where performance is measured a little bit different than performance is measured in medical and public health delivery. But I think there are many of the concepts that overlap quite closely, and there's lessons to be learned. One of the characteristics of D&I research that often is a selling point is that it crosses discipline. It's this idea of team science, that it's interdisciplinary, that it takes advantage of many disciplines. And in this case, someone working in organizational psychology or a performance improvement officer of an organization would be a benefit often to have on your your team if you're doing a D&I research study.
All right, thank you so much for that response. I hope that clarified that to the person who was asking that question. Do we have any other questions at this time? Feel free to use the button to raise your hand. Yeah, I think one thing that, sitting from the position of the core that serves for research with American Indian Alaska Native community, broadly the CDTR is really geared towards scholars who are doing research in diabetes and obesity, but what we have found is that a lot of the scholars that enter through our core may not identify themselves as health researchers in these domains, but that they're precisely because of the epigenetics and the history and other components of research that they're doing, the nexus is there. And so we just kind of help them see their research as contributing to these domains of diabetes and obesity, whether it's social determinants of health, whether they're looking at environmental research. But I think it's been an interesting process, just kind of expanding this network and engagement with the CDTR beyond those kind of two frames. So I never want folks who are interested in joining this work to feel that they might be excluded simply because they don't see themselves as diabetes or obesity researchers.
Yes, Sarah, I would say one other thing about that. I think it's also important to think about, even if you work in a slightly different area, but you have a methods issue that you think is important. We had someone in the first round of the CDTR who does work on social media and how social media impacts on health-related issues. And she would have never called herself a diabetes researcher, but I know we did a pilot study with her to look at sort of the use of social media, Twitter, and other ways for getting diabetes-related messages out there, and her methodologic areas around that. And so I think sometimes you might have some methods issue. It might be, social media. It might be network analysis. It might be some level of statistical methods, or even a method of community-based participatory research of a new way of engaging stakeholders or reaching populations who haven't been reached before, where the CDTR would be a mechanism. Because, one thing that you all know is that we are very siloed in how we fund health in the U.S., where we have the Cancer Institute, the Diabetes Institute, the Heart Disease Institute, the AIDS funding. Everybody has kind of their own silo, when in reality, we're all trying to solve the same issues just in slightly different ways. And so we're pretty open to people getting to diabetes, as you were saying, Sarah, or obesity in a different way than they would typically get there. And so that's worth exploring if you have questions about that.
Absolutely. Thank you for that background. Okay, looking to see, it doesn't look like there are any further questions at this time. Another piece that I do want to say, we keep talking about kind of membership through the center. I realize that it may not be very clear what that entails. This is not something where you sign up and pay $40 a year to access services. It's literally an application that you can submit to Jen Gallagher, whose information was shared on an earlier slide, or even to us at NCAI, and we can relay that to the center. And it's just it's a network of professionals who are able to kind of access the resources across the various cores, and that's simply it. There are some requirements to have a doctoral degree, and many people are situated in universities, but not all. There are people that are engaged in community health centers and clinics, and so just wanted to kind of share that piece about becoming a member if there is interest.
Yeah, and Sarah, I kind of mentioned this with the pilot and feasibility funding, but you have a network of professionals who have very high level people. Some of the top scholars in the U.S. are members of our group, and so you have access to them, but you also have access to funding opportunities on small grants and feasibility grants that are only open to people who are members of the CDTR. So as Sarah said, it's an easy thing to become a member of, and it's worth doing. Even if you don't take advantage of every part of it, there may be some part of it that would really help to move your work forward in whatever area you work in.
All right, we do have another question for you, Dr. Ross. This one is, can you talk about small populations and evidence-based intervention dissemination as challenges to doing this work in American Indian and Alaska Native populations, perhaps how to think about overcoming these issues? Again, small populations and evidence-based intervention.
Yeah, that's a great question. You know, that's one of the big challenges we have often with many areas of health disparities, where it's perhaps a relatively small slice of the total population, but for your example, let's say diabetes in American Indians, a group with a much higher rate and a much of a burden and disparity. And so I think the concept of small area analyses, pooling of data, in a D&I study, maybe starting out with a small study that's qualitative, that won't depend so much on having a large statistically valid sample size, but can start out fairly small, and then perhaps looking at, in a more quantitative study, looking at pooling and where pooling can happen. And I think sometimes it's, you know, let's say you're working in one tribe, and maybe that's a small slice of even the overall total population of American Indians in the United States. Maybe with those lessons you learn from one tribe could be applied to another tribe, or it could be scaled up to a much larger population. So I think it's often, it is a really good point. It definitely sort of presents a set of, I would say, sort of public health imperatives contrasted with methodologic challenges. So it's kind of those balancing things. And I think most times when it's presented at a study section that I've been part of, if you present the imperative to say, even though this is a small slice, there's such a high rate going on that we need to work on something, starting out small, building up, sort of overcoming some of the methodologic issues so that you're not overpromising on the front end, and then maybe thinking about, you know, maybe the work is, maybe I'm just kind of coming up with this off the fly, but maybe it's working in 2 or 3 various tribes and looking at things that are common and maybe some things that are different to say, here's an area where it looks like we could approach this problem in the same way. Here's some things that even in a group of American Indians, the tribe or the region or the urban versus rural or whatever the way of slicing it would be will make a difference. And so those are just a few ideas. I think, you know, that's actually a great example of the kind of things that we would work on in the next steps activity, where you'd say that I've got what I think is a really good idea to work in population X, but I'm worried that I'll run into this sort of small numbers, small population sorts of issues, and what are some ways to work through that and overcome it. Hope that helps.
And I think to the point about evidence-based practice, there have been some interesting models proposed for different communities around practice-based evidence, really trying to kind of push back on the narrative that EBP can work in all contexts and all communities, when clearly there are different cultures and histories and experiences at stake. But I don't know if you have any insights from some of the experiences you've had in these study sections about other approaches, I guess.
Yeah, and actually one of those, that's a great concept. You know, Sarah, one of those program announcements we listed was one on natural experiments, and that's largely kind of what people are looking for with natural experiments is practice-based evidence. So there's something interesting, innovative going on out there in practice that the researchers haven't yet caught up to, which is a lot of how we learn in public health and medical care. And so there are opportunities like that to frame it. And the natural experiment program announcement, I think this one is the one where they review them quickly and get the money out much more quickly than your usual NIH funding, because something might be happening now and you don't have, you know, if you wait a year or two, in the usual mechanism, the baseline data can't be collected at that point. So there's that sort of opportunity, and I think, Sarah, the idea of practice-based evidence is highly relevant and something we need to put much more focus on.
And I think one really relevant example and timely example that probably has come to mind in the Native context is, of course, looking at policy experiments such as the Navajo Nation's junk food tax. This is a policy experiment that is specifically designed to really curb rates of diabetes and obesity on the reservation. And there are researchers through the Diné College and other kind of researchers on the ground in Navajo that are collecting that baseline data currently and are really actively engaging in this work. So, thinking about those policy levers as an opportunity to engage in evaluation and precisely this kind of active research around the outcomes and effects of those types of interventions. Thank you, sir. Questions at this time. I think in a related sense, I'm curious if, like this whole kind of pushing the field to embracing practice-based evidence, have you seen more willingness to embrace kind of these culturally based interventions within these broader institutes at the national level? Is there, over time, have you observed more room for kind of cultural practice being brought in to these scientific studies?
Yeah, I do think that is increasingly viewed upon favorably. I would say a couple things. Usually that as part of a multi-level or multi-component sort of an approach is important. I would say if it's with the NIH sort of funders, making sure that you get it to the right study section. And then other funders, a lot of you are probably familiar with the Robert Wood Johnson Foundation and their large 20-year initiative they call the Culture of Health. Well, Culture of Health is exactly what you were just talking about. So maybe sometimes it won't be the usual federal funders, but other foundations like the Robert Wood Johnson Foundation, where culture is not viewed as sort of this side thing, but building a culture of health defined broadly is something that we need to do to make the overall population healthier. So that's another opportunities that might come around.
Absolutely. And thank you for referencing them. We've definitely been actively working alongside RWJF in their health equity and culture of health initiatives. So, okay, well, this is last call for questions. I want to be respectful of everyone's time. Okay, if there are any further follow-up questions, we are happy to relay them to Dr. Ross. Feel free to contact us, and we will be reaching out with copies of the slides for your viewing, and also for the link to the YouTube video that will be posted of this webinar. So thank you so much for your time. Thank you again, Dr. Ross, for sharing your insights and your wisdom in this area. Such an honor to have you sharing and representing the Center for Diabetes Translation Research on today's call. And with that, we'll go ahead and wrap up.
Great. Thanks, everyone.
Thanks so much.
Okay.